Well, good morning, everyone. Welcome to today's webinar. Welcome to the NCAS series for April. This month's topic will be presented by the Department of General Practice at the University of Melbourne. My name's Matthew. I'm one of the research fellows at the department. We've got three very good presentations today. And I'll be very excited for you to enjoy the presentations. A bit of housekeeping before we start, just to let you guys know that today's sessions will be recorded and made available on the NCAS website after this session. If you've got any questions, please put it in the Q&A sections at the bottom of your screen. Otherwise, if you want to speak live, please let us know. And we'll just keep all the questions till the end of all three presentations, and there'll be plenty of time for questions and discussions at the end of the presentation. So without further ado, I'll introduce our first speaker. Our first speaker is Dr. Ruby Biezen. Ruby is a Senior Research Fellow at the Department of General Practice and Primary Care at the University of Melbourne. She is leading a team of 8 on the research theme Infectious Disease Surveillance and Stewardship in Primary Care. She was a medical microbiologist in the hospital and community setting for the 12 years before working in the general practice setting. She completed her PhD in 2019 on exploring the knowledge, attitude, and practice of primary care providers and parents on management and prevention of respiratory tract infections in young children. Her interests include infectious diseases, antimicrobial stewardship, COVID-19, vaccination, and hand hygiene practice. So Ruby's talk today will be a quick recap of antimicrobial stewardship projects at the department. So welcome, Ruby.
Thanks, Matt. Okay, I'm actually semi-away at the moment, so I'm not sure if the presentation will be okay with the internet in near Dalesford. So I will do my best. So if I lose you, I'm still here. So just as Matt said, I'm just going to do a quick recap of all the projects that we have currently at the Department of General Practice and Primary Care. So before I start, I'd like to acknowledge the traditional owners on the land that we're actually meeting on today and pay my respect to elders past and present. So the program of work led by our department here at Melbourne Uni began with the exploratory work on how GP use electronic medical records and guidelines to make decisions around antimicrobial prescribing. So in collaboration with the National Centre for Antimicrobial Stewardship, we conducted the first ever Australian general practice study assessing antimicrobial guidelines, compliance, and appropriateness of prescribing in general practice settings. The result from the first study informed the next phase of the program, developing a clinical decision support tool, integrating therapeutic guidelines into practice electronic medical record, which are co-designed by our GPs to facilitate GP across national endorsed guidelines. So once the clinical decision support tool was developed, we conducted further research to exploring the acceptance of this tool in a simulated environment. The finding from the study resulted in the development of a quality improvement program and aimed at increasing appropriate antimicrobial prescribing in general practice and providing guidelines and patient information resources during the consultation. We piloted the AMS program in 2020. The program was acceptable to GPs and their practices. However, the sheer volume of antibiotic prescribed meant that we were not able to provide meaningful feedback to GPs to change their prescribing habit. But in 2020, we also received some funding from the Department of Health, and we co-designed patient information resources for 7 common conditions. We then piloted them across 8 general practices for acceptability and feasibility. The resources were well received and currently used in general practice. So I think it was a week before Christmas in 2023, we heard that we were successful in 2 big MRFF projects. One was led by our own NCAS Laura Hardefeld in the veterinary school. It was the Early to Mid-Career Research Grant Opportunity, COMET, And the other one was a clinical trials activity led by Bonn University, um, Professor Paul Glasiou. It's called ECPC, so it's evidence-based antibiotic stewardship sustainable implementation in primary care. So, and also in early 2024, our department was successful in securing some funding from Safer Care Victoria around building an implementation program, antimicrobial stewardship program called Antibiotic Prescribing Excellence in Primary Care, APEX PC. So here are four other projects that are currently ongoing with our department. They're actually non-funded, but it's actually led by some of our honours students in our department as well. So I'll go through all of them except for the MRFF early to mid-career. I'll leave that up to Laura whenever she's going to present on that work. So the ECPC project, we started off, there were two objectives to the project. So the first main objective is to explore the uptake of antimicrobial stewardship interventions using a primary phase in primary care. And the second phase is to trial different intervention packages to explore different intensities impacting on usage and prescribing. So to achieve these two objectives, there were two phases of the study. The first phase is a primary phase that we conducted focus groups with GPs to understand the different types of AMS interventions that GPs have used previously and explore their acceptability and feasibility in practice. And we also co-designed the packages of interventions that are considered high or low intensity. We also incorporated webinars and surveys, newsletters and advertisements through the PHNs in the different states. So the phase two is the clinical trials of these packages and interventions, and it's going into 110 practices across the 4 states in Queensland, Victoria, South Australia and New South Wales, and there will be randomised interventions to explore the effect of usage and impact on antibiotic prescribing. We're looking at recruitment and randomisation towards the next half of the year, and the intervention will start early next year. So the other project that we have just currently finished, it's the Safer Care Victoria APEX project, and that's to evaluate an antibiotic stewardship program in general practice, delivering audit and feedback to GPs supported by education webinars and information resources. The stewardship program consists of 3 cycles of audit and feedback, followed by a webinar, and algorithms were developed for 4 common infective conditions to assess antibiotic prescribing concordance to national guidelines. So 31 general practices and 96 GPs participated in the study between July 2024 to December 2025. There was statistical significance improvement in acute cystitis and otitis media across the audit periods. However, there were no significant change in prescribing for tonsillitis, laryngitis, or dental conditions. So the evaluation of the study found that we have high acceptance of the program from our GPs and agree that it provided timely feedback and allowed reflection to improve prescribing for the next audit cycle. We're working on 2 publications with some of the NCAS team, Ron, from the outcomes of this study. So the next step is that we're going to put the audit and feedback into the ECPC clinical trial across Victoria. And we also hope to get some funding to expand to other conditions such as COPD, bronchitis, and skin and tissue infections. Oh, always happens. Come on. Okay, there you go. A collaboration. So the next project is parental perspectives in around antibiotic prescribing and use. So a collaboration with the Murdoch Children's Hospital. The work started in 2021 with an honours student and a master's student exploring parents' views, knowledge, and that concerns surrounding antibiotic use and resistance. The study found that parents generally have good knowledge around antibiotic resistance and they mostly want reassurance rather than antibiotics. Parents want more information around the specific topics of antibiotic resistance and also misconceptions about antibiotics and ways that parents can reduce antibiotic use in more concise and accessible information. So, however, they didn't remember any recent campaigns around reducing antibiotic use and resistance. So the next study was to co-design and develop information resources with parents of young children that are important to them and raise this awareness of resistance. The honours student conducted 2 co-design sessions with 10 parents to produce posters that are appealing to parents and checklists for GPs and parents to use before, during and after a consultation. So here are just a couple of examples of what the honours student developed in 2024. We then had a scholarly select student based at MCRI who developed the checklist, and we hope to pilot that in emergency department and general practices soon. So the next piece of work, it's around delabeling low-risk patient with a penicillin allergy in the community. So objective 1 is to explore GP's view and experience surrounding penicillin allergy management, delabeling, and the use of fast in primary care. You'll hear more from Eleni soon, so I'm not going to spoil it for her. So we currently have another honours student doing the second objective, which is to explore parents and carers, their perspective around penicillin and allergy and delabeling. You'll hear about the outcome from that study end of this year or early next year. After that, we hope to co-design resources and processes that are acceptable to GPs, general practice and patients and carers to assist in labelling low-risk patients with a penicillin allergy label. So delayed prescribing has always been a bit of a pet hate of mine. I know that GP likes to use it, but what I want to know is what happened to the script if they don't use it, and if they are filled and they don't use it, what happens to the antibiotics? So the objectives here are twofold. So first is we want to explore the effectiveness of delayed prescribing and the context in which they're used in primary care. So we've actually got Eleni doing a literature search on what studies have been done in primary care in recent years. And the second objective is to explore the circumstances surrounding delayed prescribing for at least upper respiratory tract infection in general practice and the patient's decision processes on whether or not they fill the script and the subsequent use of antibiotics. So this will involve a study to follow the patient's journey and see what happens to the script after antibiotics have been prescribed. So last but not least, our department have been partnering with the Melbourne Medical School around general practitioner prescribing for dental conditions in primary care. So we have since published 4 papers, had 2 honours students and a PhD student just started this year to look at the prevalence of this problem in general practice and co-design tools and resources to assist GPs and dentists to improve antibiotic prescribing for patients with dental conditions. So in 2022, we had an honours student at the Melbourne Dental School to understand the reasons when GP prescribe antibiotics for dental conditions and their perception on reasons behind the dental patients presenting with dental conditions to seek GP's consult rather than dental consult. So the result of the study was published in 2022, which is down here on the right corner, and you can read all about it. So the second part is to understand the reasoning and expectations patients have around attending GPs for dental conditions. On that note, I will pass on to Yiana, who was our honours student last year doing this work, to tell you all about it. Thank you.
Thank you for the introduction, Ruby, and for the amazing presentation. Let me just share my screen. All right. Right. So, as if you don't remember, my name is Yiana Kapetanas, and today I would like to introduce my honours project, which Ruby just mentioned, dental presentations in general practice, the patient's perspective. So I was the honours student for the Department of General Practice and Primary Care at the University of Melbourne last year, where my primary supervisor was Dr. Ruby Biezen, who you just heard from, with co-supervisors Leanne Tiao and Kalaswari Somasundaram. So, if you experience tooth pain, your first thought is likely to see a dentist. Well, according to the Australian Bureau of Statistics, 28% of roughly 26,000 people delayed or avoided dental health services over the last financial year. And this raises the question, what factors lead patients to see GPs instead? So the 2024 qualitative study by our research team that Dr. Ruby Biezen just went into explored GPs' experiences managing dental presentations. So GPs reported their management options were mostly limited to prescribing antibiotics or pain relief without the tools to treat the underlying cause. And this highlights the importance of understanding patients' perspectives and barriers to accessing dental care. A Canadian scoping study identified barriers such as financial cost, low dental literacy, lack of coverage, and rurality. Yet only 4 of the 58 studies were Australian and all reflected GP perspectives. Similarly, UK research between 2014 and 2022 examined GP views, offering little insight into patient decision making. Patient perspectives remain underexplored despite being critical to improving access. Therefore, our research aimed to determine the key patient-reported barriers to dentists in Australia to determine what makes them more inclined to visit GPs rather than dentists. And our research questions were, what are the barriers that led patients to attend a GP consultation rather than a dentist for dental conditions? And what are patients' views, knowledge, or concerns that led them to attend a GP consultation rather than a dentist for dental conditions? So, the qualitative study explored patients' experiences with dental issues in a primary care context through 30-minute semi-structured interviews. So, following our ethics approval in July last year, data was collected and analysed between July and August. 11 participants were recruited based on our eligibility criteria of being aged 18 plus, have experienced dental issues like tooth pain, and resided in Victoria, Australia. So recruitment occurred through email advertisements to consumer groups within our wider department and signage in dental clinics and on campus, and snowball sampling where participants referred others that met the inclusion criteria. All our participants received a plain language statement and consent from our form outlining the study's purpose and risks before the interviews. A pilot interview was conducted beforehand to test the structure and flow. Interviews were both video and audio recorded, transcribed verbatim via Zoom, and de-identified with pseudonyms. And then our analysis was an inductive and deductive thematic approach, which we used the NVivo 15 software. So 2 researchers independently coded the transcripts, resolving discrepancies through discussion with a 3rd reviewer. So 16 patients expressed interest to take part in the study's interview. All were contacted but 4 did not meet the eligibility criteria, and 1 did not confirm a time with us. So our final sample was 11 females from metropolitan Melbourne, ranging from 18 to 60 years old. Participants had a mixture of health insurance statuses and included those who had only visited GPs and/or dentists for their dental concerns. The table presented is the breakdown of the 4 key themes, which I'll go into more detail now. So the first theme was reasons of visiting a GP instead of a dentist. So participants often went to GPs for quick relief, citing difficulties in seeing a dentist in a timely manner, either same day or within a week. Cost also influenced decisions. Many viewed GPs as a cheaper or a temporary option before seeing a dentist. Participants' perception of their ailments often would influence their decisions to see a GP or a dentist. So when unsure if their issue was dental or medical, participants turned to their trusted GPs for advice. Some even believed nerve pain in the mouth was for GPs to manage. And trust in already formed relationships with their healthcare provider played a major role. So regular GPs were seen as more approachable and familiar, making visits feel easier and less intimidating over dentist visits. The next theme, so this theme from the findings involves participants sharing their expectations of dental care. So participants recognized GPs had limited training in dental conditions. They expected GPs to offer pain relief and general advice, while expecting dentists to diagnose and treat the root cause through procedures like fillings or root canals. Participants commonly expected from GPs a prescription, and several participants described this as an interim measure until they could access a dentist. It was also expected GP consultations would result in being referred to a dentist. So even with this understanding, barriers like cost and appointment availability meant GPs were still often many participants' first point of contact. So the most significant barriers participants cited were cost, fear, and waiting times. So for cost, nearly all participants had health insurance, but whether they had dental extras determined if they considered seeing a GP rather than a dentist. So even those with extras expressed frustration of high costs, making GPs the more affordable option. It was also frequently discussed about the financial transition from parental dependence to adult independence. No longer having the parental financial support meant participants cited attending fewer routine dental visits, thus risking poor teeth health. Past negative experiences, pain, and dental equipment sounds made some delay or opt out entirely from visiting dentists. They felt GPs offered a more comfortable, less invasive experience. And then limited clinic hours and long waits for appointments added to the problem, especially for those who worked full time. As a result, several reported opting for a GP visit instead to avoid having to use sick leave or rostered days off to attend dental visits, as GPs were open after work hours and weekends. And then the end of each interview involved an opportunity for participants to express suggestions to improve the dental care access. So participants expressed a limited number of dentists available was a key reason for the long wait times. Therefore, participants suggested increases in the number of healthcare providers should improve appointment availability. To address appointment affordability, participants thought dental costs should be more transparent and that dental extras should just be a part of the Medicare insurance plan. This is due to reasoning that teeth are part of your personal health like everything else and should not be an added extra to pay for. Trust in healthcare providers was seen as an important factor when seeking care. Participants expressed concern that a dentist may be influenced by self-interest when managing their condition, thus valuing reassurance that their best interest as patients was being put first. So the findings addressed our overarching aim of identifying key patient-reported barriers, and four major themes were identified. So for the first theme, participants frequently reported limited dentist availability, particularly the lack of after-hour appointments, as a major reason for consulting a GP. So while consistent with existing literature, this study adds that participants valued same-day and weekend appointments as important convenience factors. Cost and transparency were also strong themes. Many described confusion about dental fees, which created mistrust and hesitation to seek treatment. This study extends on this notion by showing how unclear pricing communication further discourages attendance. Trust and familiarity also shaped decisions. So participants described stronger relationships with GPs than with dentists, influencing where they sought care. While other studies have also highlighted this, the current findings emphasize how these trusted relationships can override patients' knowledge of where appropriate care should occur. So when uncertain about the cause of their pain, especially with gum or nerve issues, participants often turn to GPs first, misinterpreting dental symptoms as medical problems. Participants in this study express this confusion, which suggests a need for clearer guidance on where to seek appropriate care. So regarding the expectations of dental care, participants generally did not expect GPs to treat dental problems comprehensively, but often view GP visits as an interim step before seeing a dentist. These findings, suggesting patients use GP appointments for temporary relief, reinforces concerns of antibiotic resistance and delaying definitive treatment. In addressing our research questions, multiple barriers were identified, including high costs, lack of dental insurance, long wait times, fear, and the transition from parental to adult financial independence. This study supports existing evidence but highlights how financial pressures shift behaviours from regular checkups to opting out of dental visits altogether. Overall, participants recommended greater accessibility, affordability, and transparency in dental services. Clearer pricing, extended clinic hours, and stronger dentist-patient relationships may help reduce unnecessary GP consultations and improve access to appropriate oral health care. So this study's strengths included a diverse sample in terms of age, insurance status, and healthcare experiences, providing rich insights into barriers to dental care. So rigorous, independent coding by multiple researchers enhanced analytical credibility. However, all participants were female and from Victoria, limiting generalizability. Recruiting patients who primarily visited GPs was also challenging within our project's time constraints. So, despite these limitations, the study effectively identified key barriers and provided actionable insight into improving Australians' access to dental care. Key influences identified were cost, accessibility, and fear. Future efforts should focus on increasing appointment availability, expanding the dental workforce, and improving affordability through government funding. Strengthening GP to dentist referral pathways and health promotion programs can also guide patients towards appropriate care. Future research should explore ways to enhance the GP dentist collaboration, integrate oral health training into general practice, and inform policy to improve equity across socioeconomic groups. Ultimately, addressing these barriers through affordability, availability, and education will help reduce unnecessary GP visits and promote timely, effective dental care in Australia. Thank you all for listening to my presentation, and these are the references here. And now I would like to transition over to Eleni, who will introduce her honours project as well. Thank you.
Good job, Yiana. Thank you. Nice presentation. I'll just share my screen. Right, is that okay? Right. Amazing. Well, thank you everyone for joining today. Good job, Yiana, firstly, and Ruby. Thank you for your presentation and for introducing me. So my name is Eleni, and so today I'll be presenting my honours project that I did last year. And it was titled Penicillin Allergy, What are the Perspectives of GPs Surrounding Delabeling, Utilising the PenFast Tool. And my primary supervisor was Dr. Ruby Biezen, and my co-supervisors were Dr. Matthew Suen, Professor Jason Tribiano, and Kalaswari Samasundaram. In Australian healthcare, 9% of patients report a penicillin allergy. However, what if I told you that 95% of these patients are not truly allergic? There are several reasons for this discrepancy. Firstly, viral reactions during childhood can be mistaken as a reaction from penicillin. Additionally, non-allergic symptoms such as nausea may have been misinterpreted as a true allergy. For some patients, the allergy wanes over time, and others report the allergy due to family history only. Penicillin allergic patients are typically instead prescribed alternative broader spectrum antibiotics, which can lead to antimicrobial resistance. This can cause higher rates of treatment failure, longer hospital stays, and heightened chance of mortality. To prevent these adverse events, delabeling is required. This means the safe removal of incorrect penicillin allergy labels. However, literature shows that GPs in general practice have an unwillingness to delabel. A novel validated penicillin allergy assessment tool called PenFast may aid the uptake of delabeling. It has 4 questions based on patient history, with a score of less than 3 indicating low-risk allergy. PenFast was validated as a highly accurate tool in a recent hospital study. It is simple and quick, hopefully empowering GPs to delabel. There is very limited literature investigating GP management of penicillin allergy. None are conducted in Australia, and most explore the views of hospital physicians. A recent review identified only 3 papers discussed GPs and delabeling. Additionally, there is no literature on GPs' perspectives on PenFast in Australian primary care. Therefore, our research aims to understand how GPs manage patients with penicillin allergy, their views on delabeling, and receptiveness to a penicillin allergy assessment tool. Based on this aim, our research questions were: how do GPs manage patients with penicillin allergy, and what are the perspectives of GPs surrounding delabeling and utilising tools such as PenFast in primary care? So, eligible participants were fellow GPs practicing in Australia, regular prescribers of antibiotics, and had internet access. We did an outreach where the research team used their professional network to contact GPs through email. GPs received the consent form, plain language statement, study advertisement, and a link to PenFast. Interested GPs sent back the consent form. Participants received a $50 e-gift voucher in appreciation for their time. A qualitative study design took place. Questions on the interview guide asked how GPs manage patients with penicillin allergies, views on delabeling, and on PenFast. Semi-structured interviews were conducted from June to August last year over Zoom, each around 30 minutes. Interviews were audio and video recorded and transcribed using the Zoom audio transcription. I then edited them to ensure they were verbatim and remove identifiable information. In August, data analysis began using NVivo. Another researcher and I independently coded and inductively analysed the first 3 transcripts. We then came together to resolve conflicts and reach consensus before I then analysed the rest. We interviewed a total of 12 participants, which is when we reached data saturation. Majority of the participants were females, 2 to 39 years of experience across metropolitan Melbourne and regional Victoria. From our findings, 4 main themes emerged, which were antibiotic prescribing for common conditions, management of penicillin allergy, views around delabeling, and views on PenFast. The first theme aimed to understand how GPs prescribe antibiotics. For common conditions that the therapeutic guidelines recommended penicillin as the first line, such as tonsillitis, most GPs would abide by the guidelines and prescribe penicillin. There were some instances where GPs would prescribe an alternative antibiotic, despite the guidelines. For instance, as stated by GP1, treating patients for long periods of time means they won't usually look at the guidelines. Ultimately, the most common reason reported by GPs for prescribing an alternative antibiotic was due to patient-reported penicillin allergy. The second theme investigated how GPs manage patients with penicillin allergy. If patients reported an allergy, most GPs would ask for details surrounding the allergy nature. GPs often suspected the patient had an intolerance rather than a true allergy, based on symptoms like vomiting. Patient symptoms were also typically ambiguous, and GPs stated that few people had a clear history as they cannot recall details about the allergic event. Ambiguous histories and uncertainty surrounding the nature of the allergies meant GPs were reluctant to challenge the allergy due to risks. Thus, GPs would typically manage labelled patients by prescribing an alternative antibiotic, with GP1 even mentioning that GPs are spoilt for choice. The third theme aimed to explore delabeling. Several barriers made GPs reluctant to delabel. Firstly, there were concerns around risks of patient adverse reactions, such as anaphylaxis, in a primary care setting with limited resources. Additionally, the limited consultation time reduced their ability in trying to resolve whether it was a true allergy. Time pressure was heightened when patients presented with comorbidities, like sicknesses, thus delabeling would require another consultation. Despite these barriers, GPs mentioned that a distinct advantage to delabeling was being able to give patients the first-line treatment and reducing antimicrobial resistance. To be more comfortable to delabel, one requirement was a mitigation of risks. For example, needing a controlled environment with ample resources or certainty that the patient had a low-risk history. However, GPs preferred to refer patients to clinics or hospitals for the delabeling to occur there. The final theme was on PenFast. Whilst most GPs had never used a penicillin allergy assessment tool before, PenFast was generally well received by GPs due to its simplicity. GP6 highlighted that it would fit into their workflow. However, some GPs mentioned that criteria on PenFast did not match with their clinical decision making, saying that they would have stratified patients higher than what this tool suggested. There was also implementation barriers into a primary care setting. The lack of emergency resources, staff, and time restrictions in a primary care compared to a hospital undermine GPs' willingness to use PenFast. Thus, most GPs would be uncomfortable prescribing penicillin after using the tool. GPs provided recommendations for PenFast. One was an increase in safety resources like sufficient time, nursing staff, and adrenaline. However, some GPs recommended that they use PenFast as a first step to stratify the patient and then send them to an allergist or hospital for the penicillin challenge. So just on to discussion. So GPs prescribed penicillin for common conditions, and their experience influenced prescribing behaviours. However, the most common reason for choosing an alternative antibiotic was due to a recorded penicillin allergy. Unlike GPs from other literature, many GPs in our study mentioned symptoms like nausea were likely intolerances rather than true allergies. This is reflective of how literature defines non-allergic symptoms, suggesting GPs understood what constitutes true allergies. However, ambiguous patient histories meant GPs prescribed alternative antibiotics. This addresses our first research question surrounding how GPs manage labelled patients. One delabeling barrier mentioned was that primary care is under-resourced to manage patient adverse reactions. However, the perception of risk might be overestimated by GPs, as delabeling has been proven as safe in primary care. Additionally, GPs in our study and other literature mention that delabeling is low priority when attending to patient illnesses in time-limited consultations. However, not addressing the penicillin allergy and only dealing with the patient's acute illness has been shown to result in poorer health outcomes for the patient. Despite these barriers, GPs recognise delabeling could reduce antimicrobial resistance, which is a motivator for delabeling not reported by physicians in other studies. GPs in our study and other literature view simple assessment tools favourably. Yet, despite evidence validating the safety of the tool, some GPs disagreed with certain criteria in PenFast. Furthermore, limited emergency resources and time constraints hindered the implementation of PenFast in primary care. Notably, these barriers mirror earlier concerns, thus suggesting that support from PenFast did not overcome the existing barriers to delabeling in primary care. GPs recommended increasing resources in primary care or referring the patient to an allergist after using the tool, suggesting a multidisciplinary approach. Therefore, in reference to our second research question, PenFast was well received. However, mitigating delabeling barriers in primary care or adapting the tool are essential for GPs to comfortably adopt it. So, strengths of our study was that we recruited a mixture of GPs across gender, experience, geographic location in Victoria, and familiarity with PenFast. Qualitative design allowed for nuanced recounts of GPs' perspectives, and the analysis was also robust, with interviews coded by 2 researchers. However, as participants were from Victoria, their views may not be generalisable to Australian GPs. Furthermore, selection bias may have arisen where only GPs interested in this topic may have participated. Lastly, input from patients is required as delabeling cannot proceed successfully without also their willingness. In the future, promotional campaigns could target increasing information for GPs surrounding how to safely manage patients with ambiguous histories. This could make them more comfortable to challenge allergies rather than prescribe alternatives. Future research should also investigate if integration of PenFast into a multidisciplinary model mitigates the perceived barriers to delabeling. For example, introducing practice nurses to assist delabeling in primary care. Or GPs could stratify the patients using PenFast and then refer them to specialists for delabeling challenge. Ultimately, this may improve scalability of penicillin allergy delabeling for broader antimicrobial stewardship. Thank you. Thanks. Yes. my
Yeah.
references. Thanks, Matt.
Well, thank you to our three speakers for three amazing talks. So we've got about 19 minutes left for this session. So I'll open up to the floor if anyone's got any questions for any of our three speakers, whether you want to type in the chat or if you are happy just to unmute and ask the question directly, we'll be happy with either way. Kaz?
Congratulations, guys. Such an amazing suite of work, and really so great to see the maturity of some of these projects coming through now. My question is around scaling some of these initiatives, Ruby, because having observed the Apex project, for example, is a wonderful example where we think it probably is feasible to scale. But what factors do you think need to be put in place to really drive some of these projects sort of nationally rather than, with that through, I guess a lot of what we do, and here too, a lot of it is through social networking, isn't it, and getting those into the GPs. But how do we scale some of these initiatives? Interested in your thoughts. Are the legislative drivers, say in hospitals, for everyone online, our accreditation framework is very granular and that actually drives particular activities. And I think that's been the major reason why hospital AMS is so sophisticated now. What do you think needs to be put in place?
Yeah, thanks, Cass, for that question. I guess there's a lot of barriers as well as enablers around implementing some of these changes. And as you can see, a lot of them are feasible and acceptable in general practice, but it's really around, the model of care. So the funding model is really important, not just with us trying to get more funding to do more of these implementation into general practice or in community, but it's really the funding model within the in primary care itself. So, for example, while we're banging on about how great penicillin delabeling for low risk patient might be, as Eleni rightly pointed out, we need the patients also to be engaged, because if patients aren't, then there's no delabeling regardless anyway. But for patients to be willing to do that, there's got to be, places for GPs to help out, because right now, as Jason Triviano would have told everyone here, that it could take up to 2 years or so just to get a spot to go in there. So how do we get the government to fund that? This is an important issue, not just penicillin, but AMS as well. How do we, make sure that the government actually prioritise some of these funding for the models? And it's really about general practice in primary care, how they can, help facilitate some of these as well. And also a lot of these research projects, while it's feasible, acceptable and everything, are the GPs who are really keen and enthusiastic and wants to make a change. There are plenty of those still out there that haven't been exposed to research, nor do they have time. So how do we get them engaged as well? So there's a lot of these issues that we're trying to tackle, but maybe one bit of it at a time. But I completely agree, hospitals are a lot more sophisticated than what we have in primary care at this moment. You guys seem to have already started way before primary care did, and also the funding to have developed something like the NAPS. We would love to have something similar, to be able to do surveillances in primary care, but right now we just don't think we have the funding, or the government has prioritised the funding for it.
No, Leslie's got another question, but can I just follow that up? When I read around primary care accreditation framework, because you do have one, the main focus is on, first of all areas are optional, I understand. I don't know what is mandatory specifically, other than the fact you need to use CPD and things. But there is, for the section for AMS, really relies on the elements of the clinical care standard, the 8 clinical care standards. How is which for those people online, if you're not aware, are eight quality standards around, provision of antibiotics if someone's really sick, taking micro, providing appropriate instructions to the patient, making sure the patient is aware why they're taking antibiotics. There's surgical prophylaxis one, which may not be relevant. Anyway, there's eight of them. Is that something is that disseminated at all as you were? Like, Matt, for example, do you get sent information from the Commission about those clinical care standards as a practicing GP?
I don't think we routinely get any of those sent to us, and I think the challenges of general practice is that a lot of practices are very heterogeneous. So not just because some are bulk billing, some are private billing, I guess the demographics might be very different as well. So, and GPs are very busy. A lot of them are small businesses, so it's very hard just to do anything outside of essentially keeping the business afloat, looking
Yeah.
after our patients.
Thank you, Matt.
And I think accreditation in general practice, some thinks that AMS it's a great way to actually not force but ensure GPs, have that sort of practice towards AMS. However, I know a lot of GPs are very resistant, and if you say to them, "What do you think about AMS and accreditation?" I think that was the question that was in the Safer Care Victoria project, and that Ron and I, when we interview the GPs, we asked that, and a lot of GP just throws up their hands and go, "Not another accreditation." So they see that as a bit of a barrier, not AMS itself, but accreditation process. And Matt can tell me if I'm wrong.
Yeah. I think Leslie had another question about GP dentist collaboration. So her question was whether if a healthcare plan could be extended. Um, I'm not sure if any of the speakers want to talk to that, or I
Oh,
can make
Leslie,
comment.
yeah. Oh, Leslie, I've given you access. I think you can speak
Okay.
if you want
Thanks,
to
Courtney.
elaborate on your comment. Yeah.
Yeah, I mean, I don't think GPs normally collaborate much with dentists, do they? That's a new one. I mean, it's been difficult enough to establish any collaborations with pharmacists, physiotherapies, and so on. And there are healthcare plans, but I don't think dentists are included in that. I mean, that's another possible way of trying to get GP dentist collaboration with the patient and would make the cost more accessible for the patient. But again, dentistry is not on Medicare. I mean, the GPs just are isolated, aren't they?
Yeah, the only
Yeah.
link that I found between the GP and dentist from multiple participants in the study was that there was just that referral of if they went to the GP first, it was them being kind of handballed over to a dentist, and that was kind of the extent of it.
Yeah.
And then also, I guess the concern that a lot of participants had was the cost. If they were either public or private, they had issues with cost, which also then was something that kind of funneled them towards seeing a GP, which was covered if they had the insurance. So yeah, it is kind of a major barrier that we noticed in existing literature before we conducted our study, and then was reinforced by our study that yeah, one of the main reasons was of seeing the GP first was because it was more affordable, more accessible. So they kind of just didn't really consider a dentist until they were told by their GP. I think this is more dentist related. So yeah, it would be interesting if there was some way to implement it and make people more inclined to book a dentist first if they knew it was something dental related. But yeah.
So Leanne Teo's not here, but she was here before, and she would have been great to be here to actually answer some of these questions. And I think so I don't know if a lot of people knows, but Leanne has now put together has a PhD student that I co-supervise with as well. So Ben will be doing a bit of work around exploring and understanding from the GP side and the dentist side first. And then, you never know, collaboration may happen between the two. But I think it's really about identifying what the issues are. I mean, it's a great idea, but why aren't they doing it? No, but they do have different funding models, and I think that is a problem. And dentists just do what they do best, and then they think, well, antibiotic could be prescribed in general practice. And I think that just becomes like a cycle of pain for patients who ultimately have to pay for GP and then the dentist.
Yeah, I think the only calibration that we have with dentists is basically referral, and it's unlike other allied health providers like physios or osteos, where GPs can facilitate a referral and also get some rebate for the patient via a GP management plan, up to 5 sessions in a calendar year. And unfortunately, dentists aren't funded under Medicare, which sort of makes it difficult for patients to access any funding if they are unable to sort of pay out of pocket if they don't have dental cover to do that. So a majority, from my understanding, of dental practice are private, and I think there's very limited public services for dental care. And I think the limitations of public dental care causes a lot of patients who can't afford it to delay their management of any dental procedures and just rely on GPs as a tie over until they can get into a dentist. Um, any other questions from the audience?
I was just going to
Okay.
have a question for Eleni and Yana. I guess for you guys, so this was your honours project, so a bit of insight into research. For you guys as budding researchers, what are you interested in next, or where would you like to see your work go? Who wants to go first?
Yeah, sorry. Yeah, I just took your
That's
spotlight.
right.
Um, well, we're currently in the process of publishing these papers, which is really, really exciting, and really great opportunity that Ruby has, is helping us do this. I guess the next step for my particular project in terms of delayed prescribing is, like Ruby said, we've now got another honors student doing the patient perspectives. And so, obviously, after doing these two projects together, hopefully seeing that implementation of Penfast in the future within the GP practice, which is what I personally would love to see as a result of this project, because from what I saw, there were positive views, but there were also areas for improvement in terms of implementing that delabeling. So yeah, it's more just gathering more perspectives and then seeing how to properly implement it so it's comfortable for everyone, basically. Yeah, I think that's for me.
Yeah, that's great. Thank you. And Yana?
Yeah, similar to Eleni, basically, but for my project, yeah, it was interesting because this was a follow-up on a previous study in the research team, which was the GP's perspective. So it was really interesting to see the patient perspective and seeing how they align. So yeah, it would be interesting to see how it can be implemented into some initiatives, because did solidify the barriers that are existent in Australia, because there was uh, limited literature in Australian context. So it was interesting to see it reinforced with our studies. So hoping to see it kind of promote and support its further initiatives would be really interesting. And yeah, I've really enjoyed research. I didn't really know much going into honors, like what it would be like. So even to be involved still ongoing from my honors year has been really enjoyable. And yeah, enjoying research, that has been really exciting. So being involved in the future, what Ruby would be probably doing with her research team is always exciting. So yeah.
Oh, great. Well, yeah, definitely let us know when the papers are published, and we'll happily disseminate that on our NCAS LinkedIn and socials and all the things. So, yeah, thank you.
Any questions from the audience? No? Well, I think if no one's got a question, I've got a question for Ruben. I want to leave her out. Just on the Apex study, I know that part of it was for audit and feedback, and the GP did get reports and webinars as part of the package. what did the GPs feel what they got most out of the reports and webinars for them to change their practice?
Actually, we did actually end up in the evaluation form asking them, exactly what Matt just said. There were, webinars, reporting, therapeutic guidelines, and information resources. Majority of them says, you know, one or two of them, but it was actually therapeutic guidelines, having the free subscription of therapeutic guidelines for 12 months. So I also want to point out that therapeutic guidelines is not free for GPs, so they have to purchase their own copy, or if they were part of general practice. So they felt actually the report itself and the therapeutic guidelines were the best thing as well, while the webinar gave them a chance to see what other people were doing and discussing similar issues. So that was something that we found was really interesting. So tick for therapeutic guidelines.
Thanks, Ruby. I think we've got 3 minutes left, so I think we'll wrap it up. So thank you again to the three speakers for giving us three amazing talks. Just a reminder again that the recording will be available after this session on the NCAS website. And just a plug for the next session, which will be Wednesday, the 20th of May in a month's time. And the theme for that session will be on aged care. So thank you again, everyone, for attending this session. And I'll hand it back to Courtney to wrap things up.
I was like, you did it all for me, Matt. That's excellent. Thank you so much. And yeah, we'll see you all in May. Have a lovely day, everyone. Bye.